since I've done this. I've been away for 2 weeks because I've been ill. Yes, I've had COVID. Terrible, really knocked me back. Terrible time. And so it's very good to be back. It's the first one back. So I apologize for missing 2 weeks, and I know that I've been sorely missed, and you haven't got your fix of questions answered. But don't worry, because it's all going to be remedied right here, right now. Because I am back. I'm on my feet. I'm dressed. So it's all a bonus. Significantly better than I was before. Hi, Gemma. Look at that. Gemma's on Facebook. Hi, Gemma. And lots of people here on Instagram. Hello, everybody. I'm waving at you all, and you're waving at me. Nice to be waved at. And so back. Hi, Khan. It's lovely to be back. And if you have any questions, please feel free to fire away. Be very happy to field and answer any questions you might have. And I've got some questions obviously backed up a bit. Thanks, Gemma. Thank you for that. I've got some questions, and I will answer questions as and when they come. So I'm going to fire off with this one, if it's okay, which says, why are you not offering combination procedures at the moment? Combination procedures meaning your classic mummy makeover, which is a breast and a tummy procedure. And broadly speaking, yes, we are not offering those at the moment. I say broadly speaking because there are different... it's sort of on a case-by-case basis, because a smaller procedure, so a smaller tummy tuck, I mean, some people have bigger tummy tucks than others, and some breast procedures, like, for instance, breast implants would be a quicker procedure than a breast reduction, for instance. So a sort of smaller tummy tuck, maybe a mini tummy tuck, and breast implants would probably be okay, but, a larger tummy tuck with liposuction, maybe with a lift with implants or a reduction or something, would not be okay. So it is sort of a case-by-case basis, but in general terms, I would say that we're not doing combination procedures, and there's two reasons for that. And the first reason for that is because there is some evidence, it's not strong evidence, but there is some evidence that if you have a longer procedure, then if you then went on to get COVID, you're going to get it worse than if you had... let me start again. If you have surgery and then develop COVID, you're going to get a worse outcome from your COVID than if you hadn't had surgery. And the evidence suggests that the longer the procedure, the worse that is. It seems to be in longer operations in people who are more ill, who are going to be more badly affected by it. So we try and avoid doing longer procedures in people who are more ill, basically, because there's some evidence to say that if you then went on to develop COVID, you would get a worse result from your COVID. So that's reason number one. Reason number two is that we are very aware and very anxious about the NHS and the capacity of the NHS and the workload in the NHS, and we do not want to put any workload on the NHS. So we are trying to avoid any operation that might even have the vaguest hint of needing any input from the NHS. It's very rare to need any NHS input from any procedures, and I would say I've never had to use it, except having said that, I did have one person, having said that, who was admitted to the NHS after surgery. She'd had a circumferential tummy tuck, and we could have treated her in the private sector, but she went to the NHS, and then there was all these MRSA swabs that had to be done before we transferred her back to the private, and she never got transferred back in the end. She ended up getting discharged from the NHS. But anyway, point is, you don't want to use the NHS. The point of what I'm trying to say is, so you don't want to do bigger operations which have perhaps more risk of someone, requiring NHS input. So those are the two reasons that we're trying to avoid doing bigger operations. And I know there's a lot of people out there who want mummy makeovers and these joint procedures. And I'm just saying, at the moment, we either have to stage it, or if you really want it in one go, and I totally understand it, there's a lot to be said for having it in one go, then you can wait. And maybe in time, as the NHS pressures get relieved a bit, then we may be able to do bigger operations. So yeah, those are your options really. But the moment we're not doing big operations at the moment, trying to avoid that if we can. Glad to hear you're feeling better. Thank you, Jackie. I am feeling a million times better. When you have a breast reduction, this is on Instagram, by the way. It's my Instagram screen over here, my Facebook screen here. When you have a breast reduction, can you have implants for shape? Yes, you can, Nikki Ald. Yes, you can. I've got to be honest with you, Nikki, I don't like doing that because that would mean obviously implants make your breast bigger. So if you're having a breast reduction and you want implants for shape, it's a totally reasonable question, by the way, because some people want more fullness in the upper part, which is what you get with implants. You can't really get that with your natural tissue. So what they would do is over reduce and then put an implant in to give some volume and shape. So you can do that, Nikki. The concept doesn't sit nicely with me that you're actually removing healthy breast tissue and replacing it with implant. I think implants are really good if you want your breast to be bigger. That's where they really excel. But if you want your breast to be smaller, then I think a reduction's a way to go. And I would say to you, it gives you a more natural shape. It does lift your breast having a reduction. It does give you a better shape to your breast. But I totally accept where you're coming from, because some people say, how, and this is why we need to show you photos in the clinic, because some people say, hold on a minute, I actually prefer a more full look than that. That looks a bit droopy. I always say, look, that's out of a bra, remember, in a bra, But yes, I take your point. It doesn't have that sustained fullness up there, which you can only really get with implants. But I personally don't do that technique where you would reduce the breast and then put implants in, because I don't like the concept of it. But we could discuss it. It's your body at the end of the day. We could discuss it. But I've got to declare my point. It's not a procedure that have I ever done it? I don't think I've ever done it, to be honest. I've done lots of lifts and implants, lots of reductions, but I don't think I've ever done sort of over reduction and then implant for shape. So perhaps if that's your thing, perhaps I'm not your man. Maybe you want someone who's done a few cases and who embraces the technique. Another one on Instagram and Facebook is good, isn't it? Blake's Image Consulting. Hey, I'm wanting to book ASP. How many areas can you have lipo at once? I'm looking for full body. To be honest with you, Blake's Image Consultancy, I always worry about people say, how much lipo can you have in one go? Lipo is not really something to say, oh, I won the lottery, I'm going to do loads of lipo. Lipo is for when you've got localized areas of fat that don't respond to weight loss. I hate to say it, but weight loss is the way to lose weight, not lipo. Lipo is for areas that are resistant to weight loss. And there's certain areas which respond well to lipo. The hips, the thighs, the outer thighs, not so much the inner thighs, the outer thighs, the hips, the flanks, these areas here underneath the arms, the male chest. So there are certain areas that respond well to liposuction, and so those areas can be done. And again, it depends on surgeons, and some people are bigger liposuction people are more liposuction, huge volumes and huge whole body, and that's not me. That's not my forte. So maybe again, maybe not doing very well with drumming up business here, but maybe I'm not your surgeon if you want sort of full body liposuction. That's not my thing. I'm more of a person who will look at a patient and say, right, where's the resistant areas that you can't shift with weight loss, and then let's look at addressing those rather than trying to contour the whole body. Liposuction is a surgical procedure. There are risks over under correction. You're much better off doing it with weight loss first and then looking at surgery for bits that aren't responding well to the weight loss. And sometimes people have full areas that don't respond to that. So that's where, again, I am. Nikki, I've lost shape from children. Yeah, a lot of people have lost shape, and the shape is restored with a reduction. So you do get shape back, but not quite as much fullness in the upper pole as you would with implants. So it's a question of having a look at some photos and seeing if you're happy with the sort of results you can get with implants. I've lost weight, so my boobs aren't as perky. I think I need uplift and implant for fullness at the top, but I don't want anchor scar. Okay. First thing I'd say to you, Toby, no one wants anchor scar. No one wants all the scarring on their chest. But if you want an uplift, you need to remove skin. And if you're going to remove skin, you're going to get scarring. And that means always scar around the areola. Usually scar going straight down, which would be your lollipop or your circumvertical. Sometimes scar in the fold, which is your full anchor. So it might be possible to avoid the horizontal scar and just go for a circumvertical or lollipop scar. Sometimes you get a little doggy, a little fold at the bottom. So I often give a short T, a little T in the fold there. But I totally understand that you don't want the scarring. And as I say, no one wants it. If you say to someone, do you want it or not? They'd always say no, thank you very much. But it does, the more you're scarring, the more you tighten the skin. The other thing, depending on how much of a droop you've got, and you could just have no scarring at all and just have implants. Obviously, there is a scar, it's hidden in the fold, but the shape wouldn't be as good. It's a balance, Toby. Often it's a balance. The more scarring, the better shape, but the more scarring. So you might say, I don't want scarring. Okay, well, that's fine. Maybe the shape's not going to be quite so good. That might be a compromise you're happy to accept, because no one, if we could get the same amount of result with less scarring, we do that for everybody. We wouldn't give more scarring to some people. We give the less scarring to everybody, but sometimes you need it. I didn't want it for weight loss. I had a BBL done in Turkey, I know, but too much was added to the hips and thighs. Right. Oh, so you've had surgery, you've had too much, and you want it lipoed now. Well, that's fine. Yeah, hips and thighs is a reasonable area to address with lipo. Oh my God, how do I decide what I do between Instagram and Facebook? Decisions. I need a manager. I think I'm ready. I think I'm at the stage where I now need a social media manager. I can't possibly be expected to cope with this on my own. I'm going to flick over to Facebook now. I can see Natty, you got your question there, and I can also see someone's asked a question on Instagram there. So Neil, hi Donna here. Oh, hi Donna here. Sorry. Will having vaccine make any difference? No, Donna. I had the vaccine. My dad had the vaccine, so it didn't. I mean, in general terms, they the hope is that the vaccine will make, if you do get the disease, it will be less. And maybe I got it less badly because of the vaccine. But in terms of surgery, it won't make any difference. It won't make us more likely to do surgery on you if you had the vaccine. We will still do a test on you if you've had the vaccine. We test everybody before surgery, basically. So whether or not you've had the vaccine will not give you any sort of benefit or any sort of negative if you haven't had it. It's yeah. So no, won't make a difference. Lucy, first time viewer here. Hey everyone, Lucy, ring the bell. Have we got a bell? I need a manager. I need a bell. Okay, nice to see you, Lucy. What is the recovery time for implant replacement with uplift? The girls are 21 this year and need some attention. Is Cap C? Cap C, let's go. More common on a second surgery. Had no issues with these so far. Yes, Lucy. And I've got to be honest with you, Lucy. 21 years. Go, Lucy. That's very good. 21 years is a long time for your implant, so that's brilliant. But unfortunately, Cap C or capsular contracture is at is going to happen more quickly second time round, because every time we do surgery, we introduce more scar tissue. So I always say minimize the amount of surgery you have to your breast. So you waited 20 years, which is brilliant. 21 years. So that is brilliant. So yes, your risk of capsular contracture is higher second time round. And the answer about the recovery time for implant replacement with uplift, well, we said a minute ago with the uplift, you give scars, etc. So there are scars associated with that. Those scars have to heal. So you'll be in a dressing for a week. You'll be in hospital overnight. Let's bring it right back. You'll be in hospital overnight, probably. If you have it done in the morning, you might be able to go home same day, but maybe same day or overnight, put it like that. Then you go home, and then you have all these tapes on. You come back after a week, take all those tapes off. It looks weird. Shape always looks weird after a lift with implants. So, and that week, you're not going to feel like doing much. Second week, you'll be feeling better. You'll be pottering around the house and stuff like that, but you probably won't be doing much second week. After 2 weeks, you can do the gym if you want to go with lower body, stepper, taking it easy and stuff. And then driving maybe 2 weeks, 2 to 3, maybe 2 weeks, you'd be all right for driving. So works usually after 2 weeks, as long as you're not doing anything too heavy. And it's 4 to 6 weeks before you do anything too heavy. And even then, you're just starting. 4 to 6 weeks before you can start do upper body stuff. So if you're a gym sort of person, I would say, look, take it easy. Don't go crazy after 4 weeks. Just say, oh, that's it, I'm going to go crazy, because it'll swell, it'll hurt, and it'll take ages for it to settle. So that's sort of ballpark, Lucy. I'm going to go over to Instagram. Natty, I've got my surgery with you in 6 weeks. Oh, go Natty. Lift, implants, and mini tummy tuck. How long post-op until I can exercise again? I exercise a fair bit at the moment. Weights and heat. Natty, I do know you exercise. Yes, I've seen you do exercise. You're an exerciser, aren't you? Well, you've got to be taking it easy, Natty. I tell you, because I don't want you going and overdoing it, because you'll make it swell and you'll make the recovery longer. So lift, implants, and mini tummy tuck. It's a big deal. It's a big deal. I'm going to say nothing, nada, niente, nicht, nil for 3 weeks. Obviously, walking and going out and about is good, but I say stay away from that gym for 3 weeks. After 3 weeks, you can start gently doing no impact stuff. So no running or nothing too heavy with your upper body, because that lifted implants is going to be a bit uncomfortable. Exercise bike, stuff like that, the stepper or the, what's it called, cross trainer, I believe, but without the arms, just legs. And again, you can start at about a month, 6 weeks, but just start. Don't go crazy. And I know it's going to be hard for you to hear that, because I know you probably go quite regularly at the moment, but it is going to knock you back. And I've got to be honest with you, whether I say this or not, you are not going to feel like doing stuff for the first few weeks anyway. So you just be prepared for that. Be prepared. What is the process of booking a consultation and time frame of having breast augmentation? Process is to give us a ring, 0121 454 3680, or email us or message me on Instagram or Facebook or through the website or whatever. And the time frame for having a breast augmentation is probably a couple of months. I don't know, actually. I don't know why. I should know, shouldn't I? I'm going to say a couple of months, 2 or 3 months maybe. I'm not sure. I don't think it's too bad. What should I do? I'll do Danny. May have already missed the discussion. I wondered, when having a breast reduction, can you make the areola smaller? Didn't miss that, Danny. Definitely, absolutely integral part of a breast reduction is making the areola smaller. Absolutely normal part of a breast reduction, that is, Danny, and it's like you don't have to pay or anything like that. It's just it's always done. But you can have a view. If you've got a view of the diameter, usually it's around 4 centimeters we make an areola, but if you've got a view on it, you can certainly put your oar in. Could never guarantee it'll be exactly the size that you want it to be, but you can always say, I like it to be 3.5 or 4.5, whatever, and say, okay, well, we'll use it. We have different nipple markers. But yeah, absolutely, it is the bottom line. It is an integral part. What's this? I've got a question. I missed the topic of this talk, but didn't want to miss anything. When was Staiano established, and how big is? Oh, I can't. Oh, what have I done? I can't read the rest of the question. And how big is? Okay, good. Thank you for the question. When was Staiano established? Crikey. I started around about 2007, I think, as a consultant, as a fully trained consultant. Around 2007, I think I finished my training, and that's when I finished all my specialty training. You do 6 years of specialty training, and then before that, 5 or 6 years of general training. So I started in the private practice around 2007. I then worked in the private hospitals around the Midlands. My job initially, I was in Cambridge as a locum consultant, and then I got a permanent consultant job in Birmingham, and worked in the private hospitals in the area, which I still do work at, to be honest with you. But then I opened my clinic in 2013. So I was working in the private hospitals, like most people work in the private hospitals, that's what they do. But I opened my own clinic in 2013. Who is part of your staff? So I now have others. So we have, got clinic nurse and a receptionist, clinic manager, PA, IT guy who helps me. So these are the people who help me at the clinic. Clinical staff, there are 3 of us. There's Azam Faroa, who's a skin specialist, who does a lot of the moles and the local anaesthetic work, and Kuram Khan, who does a lot of the more general stuff like me. We mainly do breast and body contouring. So there's 3 of us, 3 plastic surgeons there, and that's the score with that one. And Natty, it'll be a killer not exercising. Yes, I know it will, but you've got to just accept it, take it on the chin. I know you can do this. This is actually a question on Facebook, which is one of my questions, which is, can you do surgery on someone who has underactive thyroid? Hi, Rebecca. Thank you, Drag. Nice to see you. Yes, you can, Rebecca. And I think, lovely stuff. Look at that. I think, Rebecca, this is one of my questions, and I think that's you. Does it say that you've been turned down by someone before or by other surgeons, which is a bit of a worry? Actually, no. The question says, I have hyperthyroidism. Am I still able to have a breast augmentation surgery? I've been turned away by other surgeons. So maybe it isn't you who's asked that one. Anyway, so we've got both. We've got hyper and hypo. So, Rebecca, you're asking about hypothyroidism, which is low thyroid. And the answer is yes, it's fine. It's fine for either hypo or hyper. They can both cause problems. So underactive thyroid, which is a hypothyroidism, can make you tired, can make you lethargic, can make you put on weight. So there can be issues around having surgery associated with the low thyroid. And I think whether it's low or high can make you, can give you palpitations and can give you other sort of symptoms. So both can cause problems. And so what we would want to do with any sort of medical problem is to make sure you're pretty stable and control with your thyroid. So if you're hypothyroid, if you're on thyroxine, if that level is pretty stable and you're well controlled, if your weight is well controlled, if you're struggling with your weight and you're putting on weight, then it probably wouldn't be a good idea to do surgery. So I can see reasons why people might turn you down potentially if there are issues with weight or other things, but I can't see us certainly turning you down just because you're hypothyroid, as long as it's well controlled and well managed and you haven't got any ongoing symptoms or concerns, particularly in terms of weight loss, and it can cause mental health problems in terms of depression and low mood and things like that. And so treatment can help with stabilize those sorts of symptoms. So I think we probably want those symptoms as good as they can be before we would consider surgery. But in itself, I don't think having a low thyroid would be an issue in itself. Ada says, good evening, Ada, good to see you here tonight. Samantha says, what are your current waiting times for TT, please? I should know this stuff, shouldn't I, Samantha? I've got no idea. I'm going to say a couple of months, 2 or 3 months. What are we now? February. A couple of months. March, April, May, sort of. Sounds reasonable. But I'm not entirely sure. Nicola would really know about that. She's the clinic manager. She knows all about that sort of stuff. Lucy says, thank you, Lucy, and well done on your 21-year-old implants. Do I need to send, so I'm going to one of my preordained questions here. Do I need to send a photo before booking my S&T procedure, which is see and treat procedure, online? You don't know. I mean, you can book the, we recently set it up so you can book a see and treat appointment online. So I'm trying to make things more accessible and better for patients, because I know I personally probably like to book things online. And so, it suits me. Obviously, you can phone up, but if you don't want to phone up, you can book these appointments and book directly into the clinic online. The only issue with that is that if what you say, for instance, if it's a mole or if it's a tattoo or something, we'll give you a guide price to say, look, the price is from this. And so what we don't want to happen, or what you might have to be aware of, is that you might come and we'll say, actually, that's more because it's bigger than the original price. So we don't want you to be disappointed. And if you are disappointed, the see and treat clinics, although they do have a deposit, it's fully refundable. So there's no problem. We just give it back. If you think, hold on a minute, I'm not paying that. We're like, okay, that's fine. That's fine. Here's your deposit back. And sorry to have wasted your time, but it might be a waste of time if that happens. So that's why I think for me and for us as surgeons, you probably feel more comfortable if we've seen a photo of the lesion or the problem that you've got, so we can be more comfortable to first of all say we can do it. It might be some, you can do most things, to be honest with you, but just make sure you can do it. It might be a big tattoo or something, for instance. And secondly, to give you a more accurate quote on how much it was going to cost, so that you can be a bit more prepared. So I think it'd be better to send a photo, but it's not essential because, as I say, you can book it online and come along and we can talk to you about it there and then. So it's by no means essential. Is someone screaming in background creepy? Yes, they're watching a film next door. So yes, sorry about the screaming in the background. It's perfectly above board. It's just family stuff. I'm missing the beginning of the film. I don't know what they're watching, but that's dedication for you. Yeah. Do you offer areola reduction under general anaesthetic? Yes, we would offer, I recommend it, to be honest with you. I mean, areola reduction is perfectly reasonable to be doing. Long time no see, Augusta, is perfectly reasonable to be doing under a local anaesthetic. The problem with doing it under a general anaesthetic is two problems. First of all, you have an anaesthetist involved, so there's an extra cost involved with it. But the other problem is you have more of a hangover effect. You have more sort of drugs in your body and things. And, I'd say it's better to have it under a local if you can. If you've got some real big problem with a local anaesthetic and you really want it under general, that's absolutely fine. You can have it under general, but it would be more expensive and you would be a bit more groggy afterwards. And an areola reduction is something that can perfectly reasonably done under a local anaesthetic. But yes, if you want it under general, that's no problem. We can do that. We aim to please. Should I lose weight before an areola reduction? I mean, in general terms, any sort of body contouring surgery, you should lose weight. It's for two reasons. One, you're going to get less risk of complications of scar, wound healing problems, etc. But also that your breasts and things can change shape if you were to lose weight. And so in general, the answer is yes, you should. But areola reduction is not one of those ones where it's sort of really essential. It depends. If you're very, very heavy and you want to lose a lot of weight, then the size of the areola might change dramatically. If you lose weight, and obviously your breast size and shape might change dramatically. But areola reduction is not one of those ones where it's sort of essential. It's not going to change that much with a sort of modest weight loss. So I don't think it's not one that I would sort of over egg too much if it's an areola reduction in terms of the weight. Oh, I missed one. Do you have any more before and after photos other than those on your website? Oh my God, I have got loads of before and after photos. And you know what? Sometimes you not get into trouble, but get wound up in knots when you show too many before and after photos. So I have a slide deck that I show people in the clinic of representative cases of tummy tucks with and without liposuction, breast implants, low profile, high profile, moderate profile, teardrop shape, round shape, to try and give a representation of what can be achieved. And then I try and match that into you and your frame. But the answer is yes, there's lots of before and after photos. But as you probably found, if you went and searched the internet for photos, you can get a bit punch drunk with it all. And I think you do need guidance when looking at photos, because you have to try and look at people who are a similar frame to you. In terms of implants, you have to look at base width and things like that, not just volume. A lot of people just say, oh, those are 250, they look great. Yeah, but a 250 can be if someone's wider frame than you, a 250 implant will be a lot flatter than a 250 on you if you're a lot narrower, and it could be a completely different shape. So that's why you have to look at profile, things like that. But yeah, the answer is we have got loads of before and after photos, although I do try not to get you too sort of punch drunk with it all. Toby, can you do Crescent boob uplift for less scarring? Also, I don't want to have bigger boobs, just better shape and fullness at the top. Can all this be done with just uplift if we just uplift it is implanted needed? Yes, so better shape can be done with just uplift, Toby, yes, without an implant. And in fact, if you don't want bigger boobs, I would say don't have implants. I would say just have an uplift. But as I said earlier, you have to be aware of the shape, and it does settle. And the less scarring, the less of a lift. And I've got to be honest with you, Toby, I think a Crescent lift, which is basically a crescent taken from above the areola to lift the areola, is only really something that will be good to try and match the height of the areola if there was an asymmetry of height. It runs the risk of elongating the areola because you're asymmetrically taking some skin from above the areola, not so much from below. And in my hands, it doesn't give a significant lift. So a crescent lift, I don't think gives a significant lift. Even a circumareolar lift, which is basically a double crescent lift, it goes all the way around the areola, doesn't give a significant lift. In my hands, I start with a lift with the circumvertical. I think that's when you can get a really good lift, when you add in that vertical scar down from the areola. But obviously, it's more scarring, and that's the trade-off. You want more fullness at the top. Well, yes, that's what a lift does. It gives you more fullness, but not quite as much fullness as implants. That's why you think so. This is why you need a discussion. You need to look at some photos, and you need to see what can be achieved, and you see whether it gives enough fullness with just the lift. And if not, then yes, you can combine it with implants. But then you're in the realms of making the breast bigger. So then, do you do a reduction, of volume and put the implants in, which is a thing, as I say. And if you do want that shape, then implants do give more fullness, no question about it, than when you don't have implants. And the question is, will it be enough? And is it worth taking on the risks of implants? Because although I do a lot of implants, I always say to people, there are risks associated with them. If you can avoid them, then do. There's a lot to be said for avoiding implants. If you want bigger breasts, it's hard to avoid them, because that's the best way to get bigger breasts. But if it's just shape that's the problem, then you can do a lot to the shape with a lift alone without using implants. Is it enough? Need to have a discussion. That's the question. That's the big question. Do breasts grow? What's going on next door? After breast reduction? No. As a rule, no. I mean, there is a very rare condition called gigantomastia where they do keep on growing, and then you have to almost pretty much do a mastectomy on patients. But that's a very rare condition. No. But if you do things, they can grow. So the two things that you can do are having children and putting on weight. If you have children and put on weight, well, then yes, they can get bigger again. But they would have got even bigger if you hadn't had the breast reduction. So it's not like they're coming back. It's just like they're getting bigger like they would have done if you hadn't had the breast reduction and put on weight or had children. They'd have got even bigger than they were, if that makes sense. So when you have a breast reduction, that tissue is removed forever, never comes back again. But if you put on weight or have children, they can get bigger again. So they can grow, but it's not the reduction coming back. That's gone forever. It's just your body can, just like they can grow. If you don't have a breast reduction, they can grow. Photo. Sorry about this, Instagram. Couldn't get the photo on Instagram. We've got a photo here. Why is my scar not suitable to excision? Could you please advise what other methods I should be looking at instead? So this patient has got a scar on their face. What's the best way of showing it? Sorry. Sorry. That's the best way. So this patient has got a scar on their face, just for Instagram. It's like a sort of Y-shaped scar on her cheek, and it's tricky. It's tricky to. The thing about surgical scar revision is that it creates more scar. So a surgeon can only create scar. So we can't get rid of scars. We can just change scars. And there's a couple of things we think about when we have a scar. Is it too stretched? Is it lumpy? And the direction of the scar. Those are the sort of things. Now, this scar is flat. The color's good. It's not red. It's pretty much skin colored. It's a little bit stretched. It's obviously a traumatic scar because it's a funny shape. So it's obviously not a surgically made scar. The direction of the scar is not too bad. It's not in a disastrous direction. It's hard to know how that could be improved with surgery. It's always difficult with a photo, but in general terms, I would not be desperate, and I am not desperately positive about being able to improve that with surgery. It may be a little bit dented in, I'm not sure, maybe a little bit stretched, a little bit denting in. And if that's the case, it could be possible to revise it. But in my experience, when you revise ones which are just a little bit dented in, it looks okay to start with, and then it stretches and dents in again. And you've paid money to have it look pretty similar to how it looked before. So I don't think that would be a significant improvement. What other methods should be looking at? As I say, it's a mature scar. I don't think it looks like it's sort of over a year old. So I'm not sure whether things like scar gel Silicone would be useful at this point. So people talk about microneedling for scars. Not sure how effective that is. Not something that I offer. I've got to be honest with you. I think probably my best advice is cosmetic camouflage makeup. I hate to say it, but I think makeup would probably be your best option for that. Obviously, it's not a long-term permanent solution, but if you're going out, etc., then that would probably be your best bet and give you your best results. So, here we go. It says scar is 20 years old. There you go. So it's more than a year old. So yeah, that's where I am on that. And I'm sorry that I can't be any help in a surgical way, but scar revision is hard. If you have breast reduction and uplift and then get pregnant, does this have a significant impact? Yes. So breast reduction and uplift, an uplift is part of a breast reduction. So breast reduction and uplift is sort of like the same as saying breast reduction, because an uplift is an integral part of it. But if you get pregnant, yes, it can have a significant effect, and it's unpredictable. That's the problem. That's why we say to people, if they're thinking of having breast reduction, if they're thinking of having any sort of breast reshaping surgery, breast lift or breast implants, if you haven't finished your family and you want to have children, it may have an effect. They may make them bigger. They can stay big. Sometimes they can get smaller. They can droop. Things can happen to the shape of your breast after having children. So it is something to consider, and it can have a significant impact. I'm not saying it will, just saying it can. So if you've already had your breast reduction, then don't worry about it. Carry on and have children and do what you need to do, and don't worry about it, and maybe you'll be fine. But if you're thinking of having breast reduction surgery and you're also thinking of having a family, the surgical advice is finish your family before having your breast reduction surgery, because that will give you a more long-lasting result. So yeah, thanks for housing, Capri. Good to see you. Hope you're all right. How does Mr Staiano perform a neoumbilicoplasty procedure? Neoumbilicoplasty. My belly button was removed and replaced with a shallow dimple, so I would be particularly interested in hearing about his method of recreating a new one which is deeper if possible. It is difficult. So neoumbilicoplasty basically means making a new umbilicus, making a new belly button, and it is possible to do that, to make a new belly button. It's difficult. And this is the problem. This patient saying their belly button was removed. I don't know if they had a tummy tuck and they lost it, or if it was removed routinely. But it is difficult making something that dents in. And it's a little bit like nipple reconstruction, but the other way around. Nipple reconstruction, obviously, when patients have had breast cancer, you remove the breast and the nipple, and you have to make a bit of skin that sticks out. So a three-dimensional thing that sticks out. The scar tissue always wants to find the shortest route, which is a straight line. So nipple reconstructions often flatten off, and umbilicoplasties will often flatten off too, become shallow. You want a nice big, deep hole when you make a new umbilicus, but there's a risk that scar tissue can contract and find the path of least resistance, which is a straight line. So it is always a risk. So the method of doing it is by sort of recruiting tissue from the sides and making a dent, making a well. So it does give a little bit of scarring, and then sort of anchoring it down to the bottom, to the rectus sheath, to the bottom, and hoping that it stays. You try and give it a little U-shaped roof, so you try and make it into a nice shape, just like you do when you make a belly button for following a tummy tuck. But it is a difficult problem, and unfortunately, I have to warn you that it can shallow. It can sort of flatten off, if you like, or become more shallow over time as the scar contracts. That is a risk. Does Mr Staiano treat tubular breast syndrome? Yes, he does. Yes. So breast is probably my main thing. So I treat all sorts of breast deformity and abnormalities and breast reconstruction. And tubular breast syndrome covers quite a wide spectrum. A lot of people use the term tubular breast for quite mild problems, which can be just addressed with implants, but it can have more significant issues with the shape of the breast. Often there's a loss of volume in the lower pole, so from the nipple down there's often no breast volume in the lower part of the breast. The nipple areolar complex can be quite large and herniated and protruding, so you often have to do things around the nipple areolar complex to score it, to release it, maybe to make it smaller. and also to score the lower pole, to expand out the lower pole, to give shape to the lower pole. So it's a bit more advanced than just sort of using implants. In some cases, as I say, some cases people use the term for someone who's just got slightly small breasts, and they say, oh, it's a bit tubular or tuberous. And then other people have a much more significant issue with the shape of their breasts. So yes, it is something that I will treat, but it is a challenge. It can be a challenge for the more extreme end of the spectrum, and it often needs a combination of implants, lifts, work around the areola, scoring the lower pole, and sometimes it needs multiple procedures in extreme cases. What's going on here, Rachel? If I was redo a previous implant and uplift, will my scars become worse? Not necessarily, Rachel, no, because what we do is we excise your old scars. So when we do redo surgery, we would excise your old scars and give you new scars, and hopefully the new scars will be as good as your old scars. I don't know if your old scars are bad, then hopefully they'll be better. If the old scars are really good, they might not be quite as good, but you hope that they'll be at least as good, if not better, than your original scars. You would hope that they wouldn't be worse. I mean, can't guarantee that, but just by the fact that you're having different scars doesn't necessarily mean it'll be worse, because it'll be just a fresh scar. The old scar will be removed. I have gained 2 stone in the last 5 months. I'm now on the path to losing it. How will this now affect my thigh lift result, in particular 6 months post-op? Am I going to have stretched skin and need another thigh lift? Good question. Good question. And this is often the problem after surgery. You're welcome, Rachel. This is often the problem after surgery, that, a bit like Nikki was saying, that, you do all this exercise and you get fit, and you then have surgery and you have to stop. And then that can make you put on weight. And that is an issue. 2 stone, it's quite a lot, isn't it? And that is a worry, that you're going to put on weight and stretch the skin again. Having a thigh lift or having any sort of body contouring tightens that skin, but that skin can stretch again if you put on weight. So you have to be really careful. So I would say to you, let's be positive and let's move forward from this point, and just don't put any more weight on, and try, if you can, to get back down to your normal weight, because now you're 6 months post-op. Hopefully you'll be able to exercise, etc. Or they work with your surgeon on that one. But and then hope that the skin recoils, and hope that it's fine, and hope that you won't need another thigh lift, and be positive. Can't guarantee it, but it is always a worry after body contouring, because you tell people, don't do too much exercise, and it's a risk of putting on weight. That's why you've got to try and get the balance right. What is overgranulation? So overgranulation, this is a patient of mine who has had a breast lift with implants, and she's got a bit of a wound breakdown down at the T-junction, which is often the way with this sort of surgery, because it's very tight down there, and sometimes the body heals too much and you get a red lumpy lump at that T-junction, and that's known as overgranulation. So granulation tissue is just healing red healthy tissue, but if it granulates too much, it becomes raised, and the skin can't go across and can't heal the wound, because there's a mountain of granulation tissue in the way. So that's got overgranulation. I should have a photo of it, shouldn't I? And you treat it by dampening down that granulation tissue. So often use steroid cream or silver nitrate to try and dampen down that granulation, so that, God, they're disrespectful, aren't they? Can you hear them shouting? Honestly, they know I'm a social media influencer and I do my thing, a couple of nights off, a couple of weeks off, and they forget. So you use silver nitrate and or terracortril or some kind of steroid cream to dampen down that granulation, so that the skin can then heal across. It's not a problem. It's a bit of a nuisance, but it's just something to recognise and treat accordingly with dressings. And that's something we would do, and Vicky, the clinic nurse, would do. Hypothyroid, we've done that one. Look at this, bit of fun, bit of devilment. In your professional opinion, what is the best topping for pancakes? #pancake day. I hope you've all had pancakes. We've had pancakes. I mean, what can I say? Lemon and sugar, isn't it? I mean, it's lemon and sugar is the obvious answer to that. Having said that, I do quite like ham and cheese, and a savoury one. When John Lewis used to have that crepe bit. Do you remember when we used to go to the shops? John Lewis, you had that crepe bit in Touchwood in Solihull. I did like, I think a ham and cheese pancake is actually a meal. And in fact, I had a ham and cheese one tonight, actually. Obviously, it's bacon and meat or crepe affair as well, actually. Another going back in the day when we used to go to restaurants, and I'm not sure if crepe affair is a restaurant, outlets. But bacon and maple syrup, big favourite of the children. But I guess lemon and sugar is you can't beat it. Can't beat it. But grateful for anyone else. Should we open that up to the group? Anyway, that is my last question there. Got through it. 2 weeks off the horse. Back on again. Good bit of interaction on Instagram. I'm talking to you. And on Facebook, I'm talking to you. So that is very nice to have that. And a bit worried you might have forgotten about me. Might come back and have a bit of tumbleweed, but no. So yeah, onwards and upwards. Keep yourself safe out there. Don't mingle and do whatever they say for this. Let's get rid of this awful coronavirus, or at least do what we can to minimize the effects. And I will see you all same time, same place, right here, 7 o'clock, Facebook Live next week, Instagram Live next week, and YouTube, I believe, live. Oh, here we go. Rachel's in with a last minute question. That's what we want. Is a second uplift just as painful? Oh my God, Jackie's used a hashtag. I forgot about a hashtag. And not even asking a question as well. Thank you for the great Q&A. So Rachel, is a second uplift just as painful? Well, the first uplift, I think you said uplift and implant, did you, Rachel? So if you had an uplift and implant for first time, that's actually quite tight because you're using an implants and an uplift. If you're not going significantly bigger and you're staying around the same size, then it might be a bit less painful. An uplift isn't usually a painful procedure. Tight, yes. Uncomfortable, yes. But usually not too painful. So I hope it won't be too painful. But if it is with a new implant, but the implant's a similar sort of size, obviously first time you were going fresh with an implant, so it would have been really tight because you do an uplift, which makes it tight, and then you put an implant, it makes it tight. If you're just changing implant of a similar sort of size, then it might not be under a significant amount more tension. So let's be positive, Rachel. Let's just say hopefully it's going to be less painful. Let's be positive. It might be of a similar pain, but hopefully, as I say, it's not usually that painful even first time around. So the fact you're asking the question makes me think maybe you had a bad experience first time. My private journey, thank you. Hopefully you will come and see me soon. Clinic's open. I'm back on the track, back on the horse. Well, next week anyway, because it's half term this week. I'm doing some operating this week, but next week. And so be good to see you. Love to see how you're getting on, how that belly button's getting on. So, good. That's me. I'm out, and I better go and watch the film. I missed half of it, but see if I can pick it up. If you have any questions, please feel free to ask me or message me on Instagram or on Facebook. Rachel, thank you for your questions. Everybody, thank you for your input. And I will see you at Tuesday night at 7 p.m. next week. Signing off. Stop the stream and